Almost 51 people login ಆಗಿದ್ದಾರೆ madam. Shall I start, madam?
Please start. Please start.
Yeah. Good evening, everyone. It is my pleasure to welcome you all for today's webinar on hypertensive disorders of the pregnancy. Despite of remarkable advances in obstetric care, preeclampsia, eclampsia continue to pose a significant challenges to us. So today webinar aims to enhance our understanding of latest concepts in the prevention, screening, diagnosis, and management of preeclampsia or hypertensive disorders of pregnancy. We hope this session will provide practical insight that can be applied to day-to-day practice, and it will help us, all of us. So I will request Arun to start an invocation song. Okay, I will request Dr. Rashmi to continue the program. She is a professor and unit chief in our Basveshwara Medical College, Chitradurga. Rashmi.
Thank you, madam. Good evening, one and all. It's a great honor for me to take you to this webinar today on hypertensive disorders of pregnancy. So at the outset, I thank Kasoga for this opportunity. I would gladly welcome Dr. Rajeshri Palladi, ma'am, who is the president of Kasoga for this webinar. I would also like to extend my warm welcome to Dr. Shobha Gudi, ma'am, the Secretary General of Kasoga. My deep welcome to the chief patrons and patron of this Kasoga, that is Dr. M.J. Hiremat, sir, and Dr. Nagraj, sir. And I also sincerely welcome Dr. Suman Reddy, ma'am, President of Kasoga. And I also welcome
There is
Dr.
some echo.
Sir.
Rashmi, there is some echo. Maybe you have logged in with two devices, beta. No?
Oh,
some echo is there.
One second, ma'am. Just log out. You log out. Yes, ma'am. The other device is nearby, ma'am. So I have just logged out of it. Yeah, I extend my warm welcome to Dr. Shobha Bembalgi, ma'am, the Honorary Treasurer, and Dr. Soumya Mani, ma'am, EC member, Southwest Zone. And I also extend my warm welcome to all the speakers, panelists, experts, and the chairpersons who have accepted the invitation and agreed to take part in this webinar. I would now sincerely welcome Dr. Shobha Gudi, ma'am, Secretary General of Kasoga, to proceed with the welcome address.
My job you have already done, Rashmi, to welcome everyone. Thank you very much. Thank you. It is very heartening to see young members of Kasoga coming in and performing all the duties and welcoming everyone and conducting scientific session. I appreciate Geeta a lot for bringing in this webinar. Actually, she is so busy in her work that we had to remind her that she is chairperson of Kasoga. Then after doing that very wonderful conference at Chitradurga last year, I'm hoping that this year, under the dynamic leadership of Dr. Rajeshri Palladi, she will soon perform everything that is expected of her. So hearty congratulations, Geeta. And my sincere regards to our patron, Hiremat sir, who has recently undergone surgery and he's recovering extremely well. We bring very good news from his side that sir is doing very well, and he sends his regards to this conference. And before I hand over, I must sincerely compliment the beloved President Rajeshri Palladi, because she has actually encouraged every chairperson to perform to the best of their ability. And I'm also very happy that this time around, the chairperson Geeta has made it a point to include the Kasoga societies, and she has brought this webinar through the societies. I'm very happy to see so many societies who have logged in. Mangalore, Udupi, even Chitradurga, even Bangalore, and so many others. So hearty welcome to everyone. Over to you, Rajeshri. Over to you. Thank you. And of course, Rajeshri, I must mention, it's delightful to see Dr. Muralidhar Pai all the way from Sikkim. From the Northeast, he has come to attend this. Thank you very much. Over to Rajeshri.
Thank you, Dr. Shobha.
Thank you.
Can you see me?
The screen has been shared, is it?
No, madam, some this thing is coming, madam.
Some error happened. Yeah, we can see you, Rajeshri. Please
Okay.
proceed.
Thanks to everybody. And, warm wishes from the Kasoga family to all who have logged in here. I must say that hearty congratulations, Geeta, for starting this webinar from your committee. And we are very delighted that you have taken it up as a challenge and kept up the calendar of events designated for Kasuru. And this is the 14th week now since we have assumed office Kasoga, and every week we have had a webinar from the committee chairpersons. And Sarvatri Hita Sarva Samaja Sukhaya, which has been our logo, is to encompass all the ages of the women at all the stages of life. And we always wish that our activities will be extended to all activities in every aspect of the woman. Extremely grateful to Dr. Muralidhar Pai sir. We are so delighted to have you as the speaker, and all the chairpersons of the talks, Dr. Ravikant Gaudar, who will be moderating, Dr. Samya, and panelists who have agreed to accept this invitation. And any amount of teaching and learning is incomplete as long as we cannot be able to take control of the disease which is at hand. Every decade, something new comes up, and hence it is said that as a doctor, we are always practicing. And we are practicing only to achieve the perfection, to see that the maternal mortality is brought down by some like hypertensive disorders of pregnancy, which remain
Voice is not coming, madam.
by hypertensive disorders of pregnancy. Now, can you hear me?
Yeah.
Yeah, yeah.
Okay. So with this, I extend my warm welcome to all the members who have logged in here, and my sincere gratitude to the chief patron and patron of Kasoga, whose leadership and vision has kept us going through. And looking up to their leadership, we get our inspiration to keep this family intact and keep the morals and principles of continuing our education, our medical education and programs ongoing. And I must congratulate Dr. Geeta that the viewership has crossed 112 in her very first webinar that she is doing this year. And it's been a huge effort from everybody to make this happen. Sharing the knowledge across the states, very much possible because of the Zoom and the internet. And thanks, Dr. Muralidhar Pai sir, for accepting and being here. And always it's a delight to listen to your wisdom and vision. Over to you.
Good evening, Suman Gatti, madam. Good evening. Rashmi.
Ma'am, shall I proceed with the sessions, ma'am?
Yeah,
Yes,
yeah, yeah.
You have
Of
to
course.
invite the guests of honor.
Ma'am, Doctor.
Yeah.
Yeah. Warm welcome to Dr. M.J. Hiremat sir, and
Sir
also
is not present, so you can see
Dr.
if
Nagraj
Nagraj
sir.
sir has come.
Yes,
Yeah.
ma'am. Yeah. I would like to invite Dr. Nagraj sir to kindly address the webinar. Nagraj sir.
ಅರುಣ್ ನೋಡಿ ಸರ್ ಇದಾರೆ ಅಂತ
Sir, login ಆದಂಗೆ ಕಾಣಲ್ಲ madam.
ಇಲ್ಲ
ಎಲ್ಲೂ
ma'am.
name ಬರ್ತಾ
Sir,
ಇಲ್ಲ.
his name is not.
then please we are missing him actually. Please proceed with the
Yeah.
chairpersons. Introduce the chairperson.
Yes, ma'am. So to our first session is on the topic know the predictors of preeclampsia and deep throat. So we are honored to have an esteemed speaker with us today whose expertise and experience will undoubtedly enrich our learning. For this topic, I would like to invite the chairpersons, Dr. Shobha Syavi ma'am, who is the past secretary of Bagalkot OBG Society. Madam is a consultant at Sanjeevani Hospital, Ilkal, Bagalkot, and she has presented multiple papers and posters in various international and national conferences and conducted many CMEs and webinars. She is the past secretary of Bagalkot OBG Society, past chairperson of Safe Motherhood Committee, and she has won many awards to her honor. We welcome you, ma'am.
Thank you, Rashmi.
I would now like to welcome Dr. Anita D. As one of the chairpersons for this session. Dr. Anita is a consultant at obstetrician gynecologist at Pati Hospital, Chikballapur, and she is the current president of Chikballapur OBG Society. She had been the past joint secretary of IMA Karnataka State Branch and past vice president of IMA Chikballapur. Welcome you, ma'am.
Thank you, Rashmi.
I would like to invite Dr. Shobha Siavi, ma'am, to kindly introduce Dr. Muralidhar V. Pai, sir.
Yeah, thank you, Rashmi. First of all, I would like to say my pranams to dear Rajeshri Madam, Shobha Madam, and Muralidhar sir, and Dr. Geeta Madam for including me in this webinar. It's a great privilege to present Dr. Muralidhar V. Pai, sir. No, who doesn't know about sir? He doesn't need any introduction, but just to tell how impressive his CV is, I would like to say a few things. Sir is MD, MRCOG, FICOG, FKCOG, and FIC MCH. He is the Vice Chancellor of Sikkim Manipal University, Dean of Sikkim Manipal Institute of Medical Sciences, and Professor of OBG. He has got 37 years of great academics. He has 30 awards to his award to him, and he has got 15 international fellowships, 208 publications. He is the author of 3 textbooks. He has given 890 guest lectures, and I'm sure he'll be doing more than 1,500 in his industrious career. Most of us cannot even think of dreaming of this CV. Thank you, sir, for being such an inspiration to all of us. And now the stage is yours, sir.
Yeah.
We
Thank
are
you,
all-
Dr. Shobha, for the introduction. And I also thank Dr. Geeta for inviting me. And of course, Dr. Rajeshri and Dr. Shobha are always appreciative of me, and they always invite me to these webinars. And I definitely enjoy giving the webinars. Today, shall I just upload this?
Please share here.
Yeah.
Yes,
Yeah.
sir.
Right. Yeah, I've shared that. You can see, right?
Yes, sir.
Yes, sir, we can see. Please make it full screen. Yes.
Yeah. So, Dr. Geeta wanted me to give an attractive title for this topic. Actually,
Yes,
it
sir.
was simple predictors of preeclampsia. So I made it as know the
By different
predictors of
and
preeclampsia and be prudent. Yes. Before I jump into the topic, it's tradition that we have to just recapitulate the classification and simple definitions in 2 slides. 2020 ACOG Practice Bulletin said this is the classification, no change as such: gestational hypertension, preeclampsia or eclampsia, chronic hypertension with superimposed preeclampsia or eclampsia. Now, if the BP is 140/90, just that, it's called gestational hypertension. To this, if there is proteinuria equal to or more than 300 milligrams, or this or was not there earlier, we were only talking about proteinuria only. Now we have added or platelets less than 10 to the power of 5, or serum creatinine more than 1.1, or doubled AST, ALT, or pulmonary edema, or headache, or visual symptoms, it becomes preeclampsia. So any one of them, need not be all of them. Now, to all of that, if you add conversions, it becomes eclampsia. Now, both eclampsia or preeclampsia in the backdrop of chronic hypertension, it becomes superimposed preeclampsia or eclampsia. The first and the foremost thing that we have to understand is that preeclampsia is not just about hypertension, though it comes under the category of hypertensive disorders of pregnancy, because hypertension is the one which is the leading or most visible sign. But the problem is deeper and bigger. It's a multi-system progressive disorder. Both words are important. Multi-system is very important because it involves all the organs and systems, and it is a progressive disorder. That is also important. It worsens.
Just a minute, Dr. Pai, just a minute. Just a minute. Arun, can you see that all others are muted, Arun? Arun, are you listening?
Yes, madam.
Please mute everybody else. Huh? You can do that, no?
Yes, ma'am.
Anybody wanting to speak can request and then you can. Okay, all right. Can request in the chat box, please. And once the discussion is open, we'll open it. Huh? Okay, thank you.
Thank you, Dr. Shobha. So it's a multi-system and progressive disorder. Both words are important. Multi-system means it involves almost all the organs in the body, and it keeps on progressing or worsening till the mother is delivered. But other day, I was giving an oration in Chennai. Even after delivery, though apparently the hypertensive part temporarily disappears, but later in life, it can come back as the real hypertension. That kind of a disease is preeclampsia, especially if it occurs early onset, severe, and recurrent. So today I will restrict myself to prediction only to finish in 15 minutes that is allotted to me. During my UG days and PG days, we used to think of so many things. We also had to learn so many tests like rollover test, grip test, angiotensin test, so many tests. But now the recent advances is we are going back to the simple things like we always knew. It is a disease which affects mostly the primary gravida, or it's called nulliparity, especially in a person who had preeclampsia in the previous pregnancy. We all know that 25% of the cases will have recurrence. It is also a disease of extreme ages. A teenage pregnancy as well as very elderly pregnancy, both will be affected by preeclampsia. And if there is family history of either preeclampsia or even hypertension, such ladies are under high risk. Chronic hypertension. If a lady has got chronic hypertension, she is more likely to develop preeclampsia. And finally, there's a very close connection between hypertension and renal disease, we all know. Similarly, there's a close relationship between renal disease and preeclampsia. Not just those risk factors. Now we have understood a little deeper into that. Person having autoimmune disease, especially antiphospholipid syndrome, systemic lupus erythematosus, they are more prone for preeclampsia. In fact, the persons with antiphospholipid syndrome, they can initially have recurrent abortion. If they survive that recurrent abortion, they can get into problem of threatened abortion, preeclampsia, preterm labor, FGR. So it's a spectrum of disease. It is specific to this kind of autoimmune disease. Vascular diseases, of course, hypertension is a problem of vascular system in the body. So obviously those who have got vascular disease are more prone for preeclampsia. Diabetes, I always tell jokingly as well as seriously that diabetes and hypertension are close cousins. I think from now onwards, I must tell that they are not just cousins, they are siblings. If you have diabetes, you may get hypertension. If you have hypertension, you may get diabetes. Sometimes women having GDM without having preeclampsia, later in life, can have hypertension, cardiovascular diseases, because they all belong to one kind of body configuration, which has got dyslipidemia, vascular disease, thrombosis, and autoimmune problems. Obesity, of course, whenever you dare utter the word diabetes, obesity is already there. It is hidden in that. They are again very close friends, I would say. Multifetal gestation. When I was PG, we used to have a word called supranormal hypertension. That means whenever there is multifetal gestation, a lady may have hypertension, and this was called supranormal hypertension. But now we know it is not just that. Whenever there is multifetal gestation, there is bigger placenta, and placenta is the culprit. Placenta is a friend as well as a foe. When it is supplying the fetus, it is a friend. But for the mother, if there is poor placentation, both for mother and for the fetus, it can be a foe. Hydrops fetalis, again here there is hyperplacentosis and there can be preeclampsia. Poorly controlled hyperthyroidism, all which favor hypertension will definitely favor disease of preeclampsia. Some more in the list. Woman herself was small for gestation. That means this lady, when she was in her mother's womb, if she suffered FGR, according to Barker's hypothesis, she can develop in her adult lifehood hypertension, diabetes, coronary artery diseases. Preeclampsia is the forerunner of those diseases. FGR, abruptio placenta or fetal demise in a previous pregnancy. What does this reflect? This reflects poor vascular tolerance of the lady, or there is predisposal to preeclampsia. Interpregnancy interval increases the risk. If the interval is long and if previous pregnancy was normotensive, if it is short, if it is previous pregnancy was preeclamptic. So this interval is very, very important for us. That means, suppose the lady had preeclampsia and the interval was short between pregnancies, she is likely to develop preeclampsia. Whereas if the pregnancy was normotensive and if the interval is long, the next pregnancy almost behaves like a primary pregnancy. That's why preeclampsia is more common. Partner-related factors. Again, this goes to say the first exposure to a new antigen. Suppose it changes the partner. The new partner is a new antigen. Or with the same partner, limited sperm exposure. That means after first pregnancy, she was using barrier contraceptive for a long, long time. Even though she has not changed the partner, his own sperms behave like new antigen. After all, it is the problem of primigravida, gravida, which means the first exposure to a foreign antigen. Foreign antigen is, of course, her husband. Other risk factors like IVF, especially if you have used donor sperms. This is an exposure, new exposure. Obstructive sleep apnea. This is also a disorder of the hyperlipidemia, dyslipidemia, vascular disorders. Elevated blood lead levels. These are the new discoveries that we have found out. These women also are exposed to preeclampsia. Post-traumatic stress disorder. This is part of the hypertension or the vascular disease or coronary problem, strokes. So it will behave like a post-traumatic stress disorder. Black race, somehow black race is more prone for preeclampsia, also maybe the Asian race. Now, I gave you a big list of risk factors. Maybe it ran in 5 slides. But United States Preventive Services Task Force recommended, or they categorized this in 3 groups. One is high risk group, other one is medium risk and low risk. as it is all a risk, but again stratifying these risks into high, medium, and low. Who are the high-risk patients? Those who have had previous pregnancy with preeclampsia, especially early onset and with an adverse outcome. Obviously, adverse outcome happens in severe preeclampsia. These are the women who are more prone for having a recurrent preeclampsia. Multifetal gestation, as I already explained, multifetal gestation means bigger placenta, and placenta is the main culprit in preeclampsia. Chronic hypertension, as I already mentioned, a lady with chronic hypertension attracts preeclampsia faster and thicker than other women. Type 1 and 2 diabetes mellitus. There is no need to again impress that hypertension and diabetes are together. Renal disease, the third friend of the same triad, hypertension, diabetes, and renal disease. They go together in inviting preeclampsia. And then, of course, the new find, as I said, autoimmune disease, in that antiphospholipid syndrome, systemic lupus erythematosus. These are considered very high risk for developing preeclampsia. These are the predictors. You don't have to do any tests. You don't have to do any wonderful things. You just ask history. You will know whether she's a high risk or medium risk. The moderate risk women are nulliparity, again, the first time becoming pregnant. Obesity, obviously, she is more prone for diabetes, but not yet having. Family history of preeclampsia, not herself having preeclampsia, but family history of preeclampsia in mother or sister. Age more than 35, obviously, after that, you develop hypertension, diabetes, and also preeclampsia. Socio-demographic characters like African American, low socioeconomic levels, they also are prone. And finally, personal risk factors like history of low birth weight or small for gestational herself, previous adverse pregnancy outcomes, or more than 10-year pregnancy interval. These come under moderate risk. Now, what are the tests? As I said earlier, there were hundreds of tests. There were hundreds of things people tried, did research, but finally they came to understand that these tests have very poor sensitivity, poor specificity. So the best thing is going back to square one, that is the history and other parameters. Systematic reviews of studies that evaluated clinical available tests have generally concluded that these tests are not sufficiently accurate. That means there is no sensitivity or specificity for screening the general obstetric population. So it is futile to subject all women to multiple tests. You filter the women by the history, what I told in the previous slides, and in those probably you can do more specific tests. The overall methodologic quality of available studies are generally poor, whether it is rollover test, oxytocin sensitivity test, or whether it is grip test, and there are so many other tests. ACOG bulletin suggested take a detailed medical history and assess blood pressure to evaluate a patient's risk for developing preeclampsia. So we are now coming back to basics, very, very simple, inexpensive predictive tests. What are they? History and blood pressure measurement. Isn't it so simple? After going all over the world, all around the world, we have come back to basics. Biomarkers are, of course, have been still under investigation, such as the vascular endothelial growth factor, VEGF, placental growth factor, PLGF, and anti-angiogenic proteins like soluble endoglin and soluble FMF like tyrosine kinase 1, SFLT1. These are extensively studied. In fact, we did lots of studies, research in Manipal as well. In women who developed preeclampsia, we found that concentrations of PLGF and VEGF were lower. You don't have to do both actually. You can simply do PLGF, it will be lower. And concentrations of SFLT1 and S endoglin were higher. Again, you don't have to do both. We simply did SFLT1. So placental growth factor is low, that means poor placentation, whereas concentration of SFLT1 is high. Other lab tests were also done. Increasing evidence suggests that unexplained abnormal maternal serum analyte concentrations in first and second trimesters predict development of preeclampsia, such as pregnancy-associated plasma protein A. This we are routinely doing for actually Down syndrome screening in the first trimester. So this also predicts the preeclampsia. I am shortly going to explain how we have combined this as well as other two markers in the first trimester as the predictor for preeclampsia. Then, of course, abnormalities in cell-free DNA levels. This requires a lot of elaborate lab testing, which is not done as a routine. Uterine artery Doppler. When I was very young associate professor, when my first postgraduate student came, I gave a thesis on the uterine artery Doppler study in predicting preeclampsia. Of course, we found that its sensitivity was not very good, 60 to 70%. Specificity was there. Then we went on to do the ultrasound mapping of simple placenta. If the placenta was central, the occurrence of preeclampsia was less. If the placenta was on one side, the occurrence of preeclampsia was more. That paper went on to get prize as well. What I'm trying to say, not just the blood markers, we can also do ultrasound and placental location and placental Doppler artery, especially the uterine artery Doppler, will give us a lot of idea. Although meta-analysis show that the uterine artery Doppler analysis can predict women at increased risk of preeclampsia, most experts do not recommend these studies for screening in early pregnancy, as the false positive rate of this test is quite high, leading to excessive patient anxiety and healthcare costs. Because we know in the second trimester, there is generalized relaxation of the blood vessels, and we see that there's a tendency to drop in the blood pressure. So that's why if you do these Dopplers very early, there is a chance that you will see high resistance, but it may ease out a little later. That's why they are saying lots of false positive things can be there. Ophthalmic artery Doppler. The scientists are very desperate to have something that they can predict. If uterine artery is not good, they are going for the ophthalmic artery. Now, Yattana Mamara Yattana Kogile. So uterus is in the pelvis and ophthalmic artery is in the eyes. But the common thing is that they will tell about the vascular problem in the lady. Ophthalmic artery Doppler velocimetry has been used to predict development of preeclampsia. Similar to Doppler studies of uterine arteries, ophthalmic artery Doppler velocimetry likely has little clinical utility as a standalone predictive test for either early or late onset preeclampsia. They cannot on their own predict, but if you combine them in an algorithm, especially now with the AI, if you just put parameters, age of the patient, history of the patient, blood pressure of the patient, and these Doppler velocimetries and the markers, so you will get a beautiful score. We also know about the gestosis score, but AI is now better in predicting the preeclampsia. Detection rates of FMF London and fetal medicine Barcelona combined first trimester screening algorithms for prediction of preterm preeclampsia range from 75 to 92% at false positive rate of only 10%. This is what I was hinting at, what we tried in Manipal. So in Manipal, along with the first trimester testing for Down syndrome, we also did the other factors we put it in, that is dichromatic markers like parity, race, previous preeclampsia, hypertension, blood pressure values, actual values, and the biochemistries, especially PAP-A, PLGF, and then ultrasound findings, that is uterine artery Doppler. When all of them are put together, the AI model will give us the prediction. For example, when you put like this, you will get the values, and finally it will tell us what is the risk. 1 in 10,000 or 1 in 100,000. That means very low risk. And for late preeclampsia, also it is very low risk. Isn't it wonderful that you just put the parameters and AI will tell you what is the risk? It is better than justosis risk. It is better than any other kind of risk prediction. What is not useful definitely? Provocative biophysical tests like rollover test, angiotensin 2 challenge test, and isometric exercise. I was making mention of this in the earlier part of my talk because this is what we grew with during our postgraduate days and early faculty days. It is now not useful, not to be wasted your time. Serum uric acid, we did a thesis again, but again, it's not a very useful predictor, so it's not to be done. Screening for inherited thrombophilia, waste of time, even for predicting recurrent pregnancy loss. Only in a high-level experimental studies it can be done. APS in general population. Just because APS is a very good predictor, that is antiphospholipid syndrome, it is not advisable to do in general population. You have to first select or filter the women with high risk for preeclampsia by just history, maybe blood pressure, and then you can do this. Now, as far as blood pressure, I want to tell one more thing. You may diagnose preeclampsia at 140 by 90, but we have always been teaching in Manipal that you also have to look at the trend. Old textbooks used to mention if there's a rise of 30 systolic and 15 diastolic is bad. So let us say in the early part of pregnancy, her blood pressure was 100 by 70. Now it goes to 130 by 85. It is less compared to the definition of preeclampsia, which is 140 by 90. But you must remember that this lady has a rise of 30 systolic and a rise of 15 diastolic. Given time or in subsequent trimester, she will show up maybe late onset preeclampsia. So I hope I have clarified few things. Things have become very simple. You have to take thorough history. You have to do 1 or 2 markers only. Maybe if you have a Doppler, you can do Doppler. Put all of them together with PAPE in the algorithm. Maybe use a ChatGPT or any AI model, and you will get the prediction. Thank you so much for your patient listening.
Thank you, sir. Thank you for that detailed and but yet precise information on predictors of preeclampsia. Any questions from the audience?
Okay, we'll continue. Okay, continue, Rashmi.
Okay, so we'll now move on to the second session of this webinar. That is a panel discussion on hypertension in pregnancy, current perspective and future direction. So it's my honor to call upon the moderators for this session. I invite Dr. Ravikant GO sir, who is the president of Mangalore OBG Society. Sir is professor at Department of OBG at KVG Medical College and Hospital, Sulia. He has served as treasurer of KHI 2025, honorary secretary IMA Sulia branch. He was also served as executive committee member Foxy Society of Mangalore. He has been chairperson of endoscopic committee Kasogan 2023 to 25. He has many publications and presentations to his honor. He has also authored a chapter in OBG textbook, and he has also received Foxy Achiever Award for 2023, a Teacher Par Excellence Award at Eve Endoscopy Conference. He is also has been honored with Yuva Sadhaka Award 2024. His areas of interest are pelvic endoscopic surgery and endometriosis and fertility. We welcome you, sir. Dr. Ravikant, sir. So our second moderator is Dr. Geeta H.H. Madam. She is the chairperson of Safe Motherhood Committee, Kasoga, and she is also professor and head of professor in the Department of OBG at Basaveshwara Medical College and Hospital, Chitradurga. So, Madam has been trained in laparoscopy and ultrasonograph. She has a teaching experience of over more than 20 years, a member of Rajiv Gandhi University Board of Studies for the year 2017 to 18 and 2025. She has also received Best Teachers Award at IMA Karnataka State Branch in 2025. She had been the organizing chairperson of South Zone Kasoga in 2017 and also organizing chairperson of the 5th State Yuva Kasoga Conference held at Chitradurga. She has been participating as a faculty at many state and national conferences. She is currently the chairperson for Safe Motherhood Critical Care and Medical Disorders Committee, Kasoga. Welcome you, ma'am. I would now like to invite the experts for this panel discussion. Dr. Ramya. Dr. Ramya is an associate professor in Department of OBG at Enepoya Medical College and Hospital, Mangalore. Her areas of interest being minimally invasive surgeries, urogynecology, high-risk obstetrics, and menopausal health. She has been a member of FOXY, member of Indian Association of Gynecological Endoscopists, and also a member of Dystosis India. And she has various publications for her credit. Welcome you, ma'am.
Thank you.
So we have another expert for this panel discussion, Dr. Aparna Rajesh. She is the unit chief at KMC Attawar. Madam, she has completed MBBS and post-graduation from KMC Mangalore. She is practiced as consultant obstetrician at Bhatkal, and she completed her DNB from Father Muller Medical College. She has served as assistant professor at St. John's Medical College, and then she has served at Kshema, Mangalore. Presently, Madam is working as professor and unit chief of Attawar, Mangalore. She is a UG and PG examiner for RGUHS and NITE University, has undergone training in advanced and laparoscopic gynec surgeries, and she has many publications for her credit. She has been a resource person in multiple CMEs and given awareness talks to NGO forums and TV programs. She is currently secretary of Mangalore She has served as secretary for Mangalore Obstetric Society during 2020 and 2022. Welcome you, ma'am. I would now like to invite the panelists for this session. Dr. Lata V. Ma'am. Dr. Lata V. Ma'am completed her MS from Mysore Medical College. She is the head of the department and unit chief of Department of OBG at Basaveshwara Medical College and Hospital. Her areas of interest being safe motherhood, infertility, and preventive oncology. She had been the past president of Chitradurga OBG Society, and she is also currently the executive committee member of IMA Chitradurga. She has multiple awareness, Madam has done multiple public awareness programs on cervical cancer prevention and HPV vaccination and menstrual hygiene. She is also a recipient of Ambedkar Award for Academic Excellence, and she has been awarded on Doctor's Day Award. Welcome you, ma'am. The second
Thank you,
panelist.
Rashmi, for your kind information.
The second panelist for today is Dr. Manohar R. Dr. Manohar is an associate professor at Mandya Institute of Medical Sciences, Mandya. Sir, he's a UG and PG examiner since 2013, and he has won numerous types of prizes. So he has won during many of the conferences held throughout in national and state level conferences. And he has been serving as secretary of Mandya OBG Society in 2018-2019. And he is currently the president of Mandya OBG Society in 2025. He was also the organizing secretary for the 6th Yuva Kasoga Conference held at Mandya in 2026. He has various papers and poster presentations for his credit, and his area of interest being high-risk obstetrics and infertility. Welcome you, sir, for this webinar. I now welcome Dr. Sindhu Lakshmi ma'am as a panelist for this session. So, Madam has done fellowship in cosmetic gynecology, regenerative medicine from IISRM, and she has his fellowship in psychosexual medicine, JSSNC, Mysore. She has also done her MBA in hospital management. She is currently an admin at NJ Hospital, Mysore. So, she has won multiple awards and prizes in various conferences, national and state level conferences. And she has also won an award of Emerging Talent in Obs and Gynae Award at Muzaffarnagar Medical College. So she has participated as faculty at various national and state conferences. She is currently established in Mysore City an exclusive cosmetic gynecology and sexual medicine center. Welcome you, ma'am, for this panel discussion.
Thank you, Dr. Rashmi, for that kind introduction.
So I also like to welcome Dr. Harish KM, sir. He's the professor and head of the department at Haveri Institute of Medical Sciences, Haveri. Sir has done his fellowship in minimal invasive surgery from Galaxy Care Hospital, Pune. Welcome you, sir, for this panel discussion.
Thank you, Dr. Rashmi.
I would like to now request Dr. Ravikant, sir.
Thank you, Dr. Rashmi, for a wonderful.
Slideshow.
Yes. Yes. Good evening to all. Just now we had a very nice discussion of risk factors and screening in hypertension disorders in pregnancy. So before starting the panel discussion, I just wanted to thank Rajshri Paladi Madam, President Kasoga, Secretary Dr. Shobha Gudi Madam, and all the experts and panelists of today's function, and all the members who are joined here in a large number. We just now had a discussion of high risk factors and screening of preeclampsia. We'll like try to understand how these information can be applied in a real life situation. I just want to tell you that today's we are going to discuss two cases. One is about the preeclampsia and other is about the eclampsia. All these, whatever the clinical information is there, is based on International Society, a study group of hypertension in pregnancy, and the World Organization of Gestosis. We use these two as a basis so that we shall have a very less amount of confusion in the management of these patients. And all these guidelines are accepted by FOXI, ICOG, and Government of India with a very little modification that are catering to Indian patients. So let me start with the first case scenario. 26-year-old gravid 2, abortion 1 with amenorrhea 2 month, presented for a routine antenatal checkup. Her previous pregnancy ended up in induced abortion at 3rd month of gestation due to failure of a contraception. She had pregnancy, she didn't want to continue, so there was a termination of pregnancy was there. On general examination, all findings were normal. Routine antenatal investigations were normal. So she has just come for a first antenatal visit. So now the first question is to Dr. Lata Madam. So how do we screen for PH in this case, Madam?
So good evening, sir. So universal screening is recommended for universal screening for preeclampsia is recommended for all pregnant women. We can use the Gestosis score system to recognize the high risk factors. So in this, we give score of 1, 2, and 3 for each clinical risk factor according to its severity in contributing the development of preeclampsia. So if the total score is more than 3, we consider it as a high risk pregnancy for PH.
Yes.
This we use like maternal anemia, obesity. So many risk factors are there. Are almost 27 risk factors. Some risk factors like maternal anemia, obesity, primary gravida, they are given one risk factor. And family history of preeclampsia, gestational diabetes, obesity, multiple fetal pregnancy, like such factors are given too. And pre-gestational diabetes mellitus, chronic hypertension, mental disorders, like that, they are given the score of 3, sir.
Yeah. So this is a
like that 27 risk factors are there. Based on this, like it is available in PHCs also. Now they are doing like ASHA workers and sisters also. They are trained to do Gestosis score and refer the patients.
Yes, thank you, madam. So that means there is a freely available on a website is there. In that website, all the risk factors have been clearly mentioned. We just have to put that in that website and find out the Gestosis score for each and every antenatal mother for the first visit itself. So in our patient, her Gestosis score came as a 4, and she is a risk for preeclampsia. So that's what we learned from this. So what's the next step in the management, Dr. Manohar sir?
As this patient, according to the Gestosis score, is more than is 4, and she's an high-risk candidate for development of at risk for preeclampsia, we would like to start with ecosprin, 75 to 150 milligram. There are various studies. According to the FOXY 2026, they say if suppose it based upon the Gestosis score, you make at risk for preeclampsia, you just start with ecosprin 75 milligram. There are other studies according to NICE, they start with 150. ACOG tells 81 milligram to be started as for a prevention of preeclampsia.
Yes, sir. We just want to clear this doubt. So according to the World Organization of Gestosis, if the risk factor is found by Gestosis score, we have to start with the 75 milligram aspirin. So, okay, thank you, sir. Thank you so much. So next is, when should we start? Sindhu, madam, when should we start ecosprin?
So this ecosprin has to be started as early as possible, sir. Preferably less than 16 weeks. But there are studies to show that even though if it is started delayed also, there are certain benefits with it. But in order to reduce the problems associated with the risk factors, it's always better to start as early as possible.
Yes.
Once we do the risk factor score management is done, it should be started.
Yes, sir. That means whenever the placentation was happening, at that time, as early as possible. So it should be started. At least if the patient comes late also, even before 16 weeks or up to 20 weeks, the benefit is there. Is there any other supplements to prevent preeclampsia? Dr. Harish, sir.
Yes, sir. The calcium supplements can be given at a dose of 1.5 to 2 grams per day, which will decrease the release of parathyroid hormone and decrease the intracellular calcium, and thereby reducing the smooth muscle contractility. So, but still they don't have experimental support regarding this, but still some amount of severity of preeclampsia can be reduced. So this has been found out in this one patients who had diet deficient in calcium. So along with that, oral vitamin D also can be given at a dose of 1000 to 2000 international units per day. But current evidence preventing preeclampsia is weak even with vitamin D.
Yes, thank you, sir. So there are so many supplements we used to give for preeclampsia. We used to give for antenatal mothers to prevent preeclampsia. Now currently there are only 3 things: ecosprin, elemental calcium, and vitamin D3. These are the only 3 things which are going to reduce the risk of preeclampsia. So in our patient, she underwent a routine first trimester NT scan, and in her NT scan showed that mean artery means uterine artery Doppler means pulsatility index was more than 2.35. So that was more than the 95th percentile for her age. So which showed it was a positive risk factor for pregnancy-induced hypertension. One Gestosis score is also positive, and also NT scan is also showing the abnormal mean pulsatility index of the uterine artery. But in this case, placenta growth factor test was not done in our patient. So what is the change in the management, Lata madam, now?
Sir, we can increase the dose of ecosprin to 150 milligram for this patient. And like I don't know about others, sir, but I also use nitric oxide donors like amino acid supplementation for such patients. I want opinion from other panelists and experts about nitric oxide donor for aspect.
Yes, thank you, madam. We can.
Am I audible?
Yes, sir. Yes, madam. You are very well audible. So, as the FOXY guidelines is suggesting, that if there is a risk factor is from Doppler abnormalities, then the better to start with the 150 milligram. If the only history or Gestosis score is the abnormality, then 75 milligram ecosprin is there. Other modes of treatment, nitric oxide donors and all, they are not clinically significant, but we'll ask our expert to put their opinion since there is a difference of opinion is there. Aparna madam, do you want to put anything? Aparna or Dr. Ramya?
Sir, can I add a point, sir?
Yes, madam, please.
Sir, here the importance lies in the compliance of taking ecosprin, sir. it's very important that the patient is very compliant, and minimum of 90% compliance is required for the risk reduction. And this ecosprin for the reduction of the risk factors should be taken up to 36 weeks. So this is one point I'd like to add for the ecosprin.
Thank you, madam. Thank you. Definitely, it is going to reduce the preeclampsia risk by nearly 70%.
Yeah,
Yes.
studies have shown even maybe 1 week or 2 to 3 days before her delivery expected date, you can stop ecosprin.
Nice.
Studies have shown that it is beneficial. Even
Aparna,
if you continue till. Yeah,
that-
that's what. And regarding nitric oxide, not much
Yeah.
studies, but if there is oligohydramnios or any other features, then definitely there's a role for starting nitric oxide. Otherwise, maybe we can ask the patient to come for regular follow-up, more vigilant examination, checkup for BP can be advised to such patients. And starting off and regular taking of aspirin is one more thing we have to counsel and tell, and more frequent checkups. So blood pressure checkups is advised, mandatory in such patients.
Yes, thank you, madam. Thank you. So routinely for all antenatal mothers, irrespective of the risk factors, whether risk for preeclampsia is there or not, each and every antenatal mother should have been explained clearly about what are the warning symptoms of preeclampsia, like headache, visual disturbances, epigastric pain, vomiting. And if there any of these symptoms come, they should visit the treating doctor. Okay. So she was uneventful till 32 weeks of gestation. Then during routine checkup, her blood pressure showed 145, 90 millimeter of mercury, which was recorded 2 times at 4 hours apart. Dr. Manohar sir.
Yes, sir.
What's the next step in the management of
Sir,
PH?
the blood pressure is 140 by 90 millimeter, recorded 4 hours apart, 2 readings. I would like to get a urine protein, sir. So test for proteinuria, as there are various definitions, like if the urine dipstick is more than 1 plus or equal to 1 plus, and if there is a urine protein creatinine ratio of 30 milligram per millimoles, or you can get a 24 hours urine protein of 300 milligram per deciliter, or creatinine to albumin ratio as 8 milligram per millimoles. So we can get for test for proteinuria, sir.
Yes, thank you, sir. The most sensitive is creatinine to protein, creatinine, urinary protein to creatinine ratio is the most sensitive. But if it is not available, even the 24-hour urine protein is also equally good. But dipstick test can be kept at the last, where facilities are not available. We can go for dipstick test. Okay, thank you, sir.
Yes.
So once the proteinuria is established, no further testing for proteinuria is required, because if the proteinuria is 3 plus, 4 plus, and above, it is not going to affect the management. I just wanted to put one word about the proteinuria. So once the proteinuria is there, it means that it's a preeclampsia. It's not a gestational hypertension, but no need to further test for proteinuria. What other investigations are necessary in non-severe PH? Sindhu, madam?
Here, yes, sir. So here we have to do both the metal monitoring and the fetal monitoring. So we require other baseline investigations like a complete blood count to look into whether her platelet levels are dropping. She has thrombocytopenia. We have to check her hemoglobin levels to assess whether she is having anemia or not. We have to do liver enzymes, the alanine aminotransferases, aspartate transferases, because these are going to be increased in case of preeclampsia, due to doubling of the enzyme values, and also serum creatinine, because this also will be increased, something around more than 0.8 to 1.2. For the fetal monitoring, we have to do a growth scan along with the Doppler assessment. We have to look at the placental localization, and also we have to look into the Liker content, the AFI.
Thank you, madam. So here, just want to remind you that if it is a non-severe PAH, that means target damage, organ damage is not there, or warning symptoms are not there, and the blood pressure is less than 160/100. These are the minimum investigations that are necessary: protein, complete blood count, liver enzymes, and serum enzymes. And as madam mentioned, if necessary, only then you can go for a Doppler. Okay, thank you. So in our patient, the proteinuria was 2 plus. When do we need additional investigation like coagulation profile and fundoscopy? Hari sir?
Sir, coagulation profile can be done only when the platelet count is less than 1.5 lakh per cubic millimeter actually. And fundoscopy, if there is visual symptoms are there, so then we can do the fundoscopy to see whether the papilledema is there, and ultrasonography can be done to see the fetal surveillance, like fetal kick count or fetal this one tone, then to see the placental morphology, and also to detect the intrauterine growth restriction and oligohydramnios also, the UA ultrasonography can be done, sir.
Okay, thank you, sir. Thank you so much, sir. So here we can now understand that only if it is a severe PAH, that means if there is IUGR, oligohydramnia, or patient is showing a warning symptoms, only then further testing like coagulation profile or fundoscopy is necessary. So that we can triage the patient, which patient needs what kind of investigations. So optional depending upon the facility available. So some gestosis score mentions that 2D echocardiography may be indicated in certain women. So Dr. Ramya, if she is there, she is doing research on it. Dr. Ramya, are you there, expert?
Yes, sir.
Please put a on it.
Yes, sir. In our institution, we are doing routinely the echocardiography for all the antenatal women. So we have found that there were some minimal changes, like most of the times it's the regurgitation, could be a physiological. But what we found out, if it is a multivalvular findings, if you have noticed, then we have to repeat. We were repeating the echo in the postnatal period also, like after 6 weeks and 6 months. So as of now, we have not found a major effect on echocardiography, but we are finding some of the multivalvular diseases, sir. Then some of the cases we have even found the undiagnosed mitral stenosis and the pulmonary artery hypertension as well. And one of the cases we had even found the Marfan's coarctation of aorta, and we had to refer the patient on emergency basis for further higher centers, sir.
So thank you. That means a gestosis organization shows that 2D echocardiography, if the facility is available, better to be done, and definitely it is going to improve the morbidity of the patient. And MRI brain is necessary only if the patient is having a diagnosis dilemma of eclampsia, like a CVT or Press syndrome or cerebral accidents are suspect. Only then MRI is necessary. Okay. So should we start antihypertensive drugs in this case? Madam, Lata, madam?
Once more than 140/90, it is better to start them on antihypertensive drugs. And if per day, it is better. 200 gram, we start with 100 to 200 milligram twice or thrice a day. Then we can go on increasing maximum up to 2,400 milligram
Talk about
per day.
Madam, just definitely both the study groups, World Justice Organization and ISSH, we both suggest that antihypertensive are safely started once the patient, if the BP goes more than 140/90 millimeter of mercury. So now comes this, which antihypertensive is preferred? Manohar sir?
Normally, we start with the first line as labetalol, which is an alpha and a beta blocker with the dosage of about 100 milligram or BD twice daily, or with 200 milligram to BD, or 3 times daily can be used for a maximum of about 2,400 milligrams per day. And contraindications can be, one is an asthmatic, or it can be a diabetic or CCF, sir.
Yes, that is most important. So any patients who are starting a labetalol, make sure that patient is not a case of asthma, at least, because it is very routinely coming across. So other less common conditions can be congestive cardiac failure, diabetes mellitus, and undiagnosed bradycardia also should be identified. Thank you, sir. So nifedipine also can be used as a second line, like first line drug only if the labetalol is not available. Okay, thank you, sir. But most importantly, we should understand that nifedipine should never be used sublingually in any of the patient, and it should be careful in the patients where maternal tachycardia is there, palpitation, headache, and facial flushing is present. And if there is a persistently high blood pressure, what should be the management?
So target should be within 140/90, usually around 135/85. So if there's no control with monotherapy in the mid dose range, then it's always better to add a second line of drug along with the first drug.
Yes, madam. Thank you. Like suppose the patient is already having 100. Yes. So in the mid-range, if the patient is already on a 200 milligram of labetalol, now we can add the 20 milligram of nifedipine to the same patient, so that when the patient is having both the drugs, the control of blood pressure will be much better. That's what we wanted to tell. So most important is the contraindicated antihypertensives in pregnancy. At least these antihypertensives should never be used in a antenatal mother, like AC inhibitors like enalapril, ARB blockers like telmisartan. So these antihypertensive should not be used. Okay. So how do you manage a severe preeclampsia? Hari sir?
So severe preeclampsia can be managed with this one initial dose of labetalol IV injection, especially actually, sir. So IV injection is started at a dose of 20 milligrams, and this one it is given over after over 3 to 5 minutes, and then watch for the blood pressure. And even if it is not controlled, then dose can be doubled after every 20 minutes actually. So 20 milligrams can be converted into 40 milligrams after 20 minutes, then again 80 milligrams like. So total of 300 milligrams can be given over a period of time, sir.
Thank you, sir. That means labetalol intravenously can be doubled once you give
can be
over a
doubled.
period.
And the contraindication remains same for this one. What oral drug was there?
Asthma, cardiac. So definitely, any patient with a beta blockers, we should think that patient is not a case of asthma or diabetes mellitus, and just cardiac failure, and undiagnosed bradycardia is not there. So definitely that should be taken. And most of the time, with the 80 milligram, most of the patients will be coming under control. But most important is maintenance. Once the BP comes back to normal, should not leave it like that. So usually 100 ml, one is 4 ml ampoule is available, and next is 40 ml vial is available. So this 40 ml vial in 100 ml of normal saline, 40 ml of normal saline should be removed, add 40 ml of labetalol injection, and run at the rate of 10 ml per hour, so that blood pressure is maintained at least for 3 to 4 hours after the severe hypertension has come back to normal. Thank you, sir. So here, in some cases, nifedipine also can be used, 10 milligram, 30 milligram, and maximum dose is 120 milligram, but never ever should give a sublingually. Okay. So in this case, how much fluid should be allowed in these patients of preeclampsia? Lata, madam. Your voice is breaking, madam. We cannot hear you.
Hello?
Yes, madam. Now we can hear you.
No, Lata, we are not hearing you.
Yes, madam. Madam is not. I think network failure is there.
You only continue, sir.
So 80 ml per kg per hour can be 80 ml per hour can be given, sir, actually, or 1 ml per kg per hour. This one either ringer lactate or normal saline can be given. This is actually to prevent the pulmonary edema and death actually. So, and the common fluid that can be given is crystalloid like ringer lactate or normal saline, and colloid should never be given in case of hypertensive disorder.
Yes, thank you, sir. That means preeclampsia is a vascular contraction is there. So yes, they will not withstand both the reducing the blood pressure, they will not withstand the increase in the volume. So they should be in the narrow range, they should be maintained. So fluid restriction significantly should be maintained, but it should not be more than 80 ml per hour. And definitely pulmonary edema and maternal deaths are very high with the volume overload is there. Can we give antenatal steroids in case if it is necessary?
Yes, sir. Suppose the patient has come with less than 34 weeks of the preterm labor with good uterine contractions, or if the patient has come with a leak PV, a PPROM, conditions can be given, sir. Or in suppose if you plan for an elective induction, either because of the maternal or fetal indications, you can give dexamethasone, 6 milligram 12th early, 4 doses can be given, sir, according to the IPA.
Yes. Thank you, sir. Thank you so much. Means, whenever there is a established preterm labor is there, antenatal steroids can be safely given even in a preeclampsia patient also. So most importantly is just because for the giving the sake of antenatal steroids, we should not postpone the delivery unless the patient is safe. Only if the patient is safe, blood pressure under control, and symptoms are under control, only then that we should give an option for giving a antenatal steroids. So which steroid and how much is the dose? Lata madam?
Sir, we give both dexamethasone and betamethasone can be used. Dexamethasone is used at the dose of 6 milligram intramuscularly every 12 hours for 4 doses. It is betamethasone 12 milligram intramuscularly 24 hours apart, 2 doses. Sir.
Yes, thank you, madam. So here one would what Foxy guidelines has mentioned, even in the ACOG guidelines is also mentioning that both dexamethasone and betamethasone are having equally effect in the prevention of respiratory distress syndrome. But some of the studies are showing that dexamethasone has a little higher but not clinically significant value in reducing the chance of intraventricular hemorrhage. So they recommend to use dexamethasone than betamethasone. And one more thing they are telling that betamethasone is coming in the combination of acetate phosphate and sodium phosphate mixtures in injections. But in India, only acetate phosphate is not available. So the government of India is recommending to use dexamethasone 6 milligram intramuscularly 12 hours apart for 4 doses. So this is the only difference that we found out in this guideline. So dexamethasone is preferred over the betamethasone, but betamethasone and dexamethasone both are having an equal effect. The only advantage is not clinically significant, but still less chances of intraventricular hemorrhage are seen when a patient is given a dexamethasone for a preterm prematurity. When do we give magnesium sulfate injection for a neuroprotection? Yes, madam. Please continue, madam.
When very preterm birth is imminent, sir, to reduce the risk of cerebral palsy, so neuroprotection is required. That is when you're delivering prior to 32 to 34 weeks. Then we have to start this injection MaxSelf, and it has to be started minimum of at least 4 hours prior to the delivery of the baby.
Yes, thank you, madam. That means whenever the extreme preterm is there, like 24 to 32 weeks of gestational age, when there is a imminent delivery is there, then only we should go for a magnesium sulfate. So what is the dose of magnesium sulfate? Harish sir?
The dose of magnesium sulfate, like 4 grams intravenous loading dose can be given for 20 to 30 minutes. Then after that 1 gram per hour IV infusion can be continued over a period of time till the delivery occurs or up to 24 hours or it can be stopped after 24 hours if undelivered. Sir.
Yes, thank you, sir. That same dose what we give for eclampsia.
Regimen.
IV regimen.
Regimen, yes.
4 gram loading dose over 20 to 30 minutes. And then 1 gram per hour should be continued at least for 24 hours.
Like same Zuspan regimen.
Yes, sir. Thank you, sir. So when should we terminate the pregnancy for a reason of preeclampsia? Lata madam?
Sir, if it is preeclampsia without severe symptoms, we can wait up to 37 weeks. If it is severe preeclampsia, between 34 to 37 weeks, if it is imminent eclampsia, if it has eclampsia, then
yes, madam. Thank you, madam. Thank you. Like means any patient of preeclampsia should not continue the pregnancy more than 37 weeks. That's what we want to tell. So once the patient reaches 37 completed week, patient should be delivered, even if the patient is under control. And any patient who is having a warning symptoms or target organ damage is there, they should be delivered between 34 to 37 weeks, or if it is earlier, after the dose of antenatal steroids. But if the patient is having a worsening symptoms, irrespective of the gestation, because delivery is the only treatment for preeclampsia. So once you delivered, once the placenta is out of the patient, out of the uterus, all the preeclampsia symptoms will reverse. So this is the only treatment for preeclampsia is to deliver. So that should be taken care to reduce the morbidity of the patient. So this completes a simple case of preeclampsia. Now we'll consider the one case of eclampsia. A 27-year-old, 37 weeks of gestation presented with abdominal pain. She had history of headache since morning with 1 episode of vomiting. On examination, her blood pressure was 160 by 100 and deep tender reflexes were brisk. Abdominal examination revealed term size uterus with a left occipital anterior position. Fetal heart rate was 140 per minute regular. Her per-vaginal examination showed cervix was uneffaced. It was soft and posterior. Routine investigations were within normal limit, and NST was also reactive. How to manage this case, Manohar sir?
So this patient is having a primary gravida with high blood pressure of 160 by 100 millimeter of mercury, along with the imminent symptoms like headache, blurring. So it has to be treated as an imminent eclampsia, and we give an anticonvulsant line of management as well as antihypertensives. Because she's got headache, blurring has to be given according to the Pritchard's regimen, what normally we follow in our institute. So that can be given. And antihypertensives, immediate blood pressure, you can use a labetalol. Or labetalol can be given in this particular case.
Yes, thank you. Thank you so much, sir. So both patient should be given an antihypertensive and patient should be given a magnesium sulfate apart from other routine management. What is the dose of magnesium sulfate? Sindhu, madam?
There are various regimens followed, but the most commonly preferred one is the Pritchard regimen. The other one is the Zuspan regimen. So in the Pritchard regimen, a loading dose of 14 grams is given, wherein 4 grams is given IV over 5 minutes, and 5 grams on each buttock. So total of 10 is given, and followed by a maintenance of 5 grams every 4 hours. Zuspan, the same loading dose of 4 grams is given, followed by 1 gram per hour as a maintenance dose.
Yes, thank you, madam. Means both the regimes are equally effective in reducing all the effects of eclampsia. The only advantage is that if you give an intravenous regime, the gluteal pain or gluteal, whatever the complications of gluteal injections will be very much less. So wherever the facility is there to manage the serum magnesium level, monitor serum magnesium level, there better to go for a Zuspan regime. Where such facility is not there, or where you're working in a peripheral area, then Pritchard regime is safe. This is how we can divide the regimes. She threw one conversion within 5 minutes of giving a 4 gram IV med. So what should be now, Hari sir?
So we can wait for 15 minutes until this one convulsion settles down and repeat this loading dose again. So half of the loading dose, whichever that we have given, 4 grams we have given as a loading dose. So 2 grams can be given. We can repeat that dose, sir.
Yes, thank you, sir. That means patient has just come and we were just giving the magnesium sulfate, 4 gram was given. So we just finished giving 4 gram or 5 minutes and then patient threw a convulsion. So now immediately no need to panic. Better to make it little, means half a dose of, as sir mentioned, magnesium, 2 gram of IV magnesium should be given. And then if the patient is, most of the time, the patient will respond to this. What are the parameters to be checked before giving the next dose? Lata madam?
So usually we check deep tendon reflexes, respiratory rate and urine output. Reflexes should be present and respiratory rate should be more than 16 per minute and urine output should be more than 100 ml in last 4 hours. If all these criteria are met, then we go ahead with the maintenance dose of 5 grams in Pritchard regime, sir. That is, we have to check all these every 4th hourly before giving maintenance dose in Pritchard regime. In Zuspan regime, every hourly we can check for these parameters.
Yes, thank you, madam. Thank you so much. So how do you manage the toxicity of magnesium sulfate? So usually the management will be urine output. Yes, sir. 1 hour, sir.
Sir, suppose if the urine output is less than 100 ml per last 4 hours, we reduce the dosage, sir, of magnesium sulfate. Suppose you are following the Pritchard's regimen, you can just, instead of 5 grams IM, you can just give 2.5 grams IM every 4th hourly. And suppose if you are following the Zuspan regimen, the infusion rate has to be reduced to 0.5 gram per hour instead of 1 gram per hour.
Yes,
that is it. Okay, sir.
Yes, sir. Next is absent patellar reflex. How do you manage that?
So usually the normal therapeutic range of magnesium is around 4 to 7 milliequivalents. And the first to disappear when there is magnesium toxicity is the patellar reflexes. So it's important that we wait for administration of the next dose till the reflexes appear. So this happens when we are monitoring the rest of the parameters. The respiratory rate is within normal limits, the urine output is within normal limits. It's only one absent patellar reflexes, then we can wait until there is reappearance of the patellar reflexes before the next dose.
Thank you, madam. So once the patellar reflex is absent, definitely wait for some time, and then only if it is present only, then next dose should be repeated. A respiratory depression, if it is there, Harish sir.
So respiratory depression is a grave sign. So it occurs at a high dose of this one magnesium sulfate around 10 to this one 12 milliequivalents per liter. So at that time we need to administer the calcium. If it is already administered calcium gluconate, then it is okay. But if the respiratory depression occurs, the calcium gluconate has to be given 10 this 1% of the solution, 10 ml over 10 minutes has to be given. Then respiratory signs has to be monitored by giving this one pulse oximeter or ECG monitoring, and put her on recommend position to make her breathe easily, and give oxygen by mask around 8 to 10 liters per minute, and maintaining the airway also. So these conservative measures has to be maintained to give support to her respiratory system.
Grave sign, immediately we should stop the magnesium sulfate and support the respiratory system. Yes. Sir. So how do you manage the recurrent conversions? Lata madam?
So like it is almost like a status eclampticus. We can call anesthesiologist for managing such cases. They usually give thiopental, sodium, and then she'll be put on ventilator, sir. Such patients to prevent injury to the brain and other complications. Better to put them under sedation by giving thiopental sodium.
What we understand is that whenever the repeated conversions are there, involve the multidisciplinary team, anesthetist, physician, they should be involved, and then the management should be continued.
Can I say something here, Ravikant and
please, madam.
Geeta? I just wanted to, just wanted to tell here that there is a strong role of injection Levipral here, and also injection, phenytoin sodium also is used sometimes.
Yes,
But,
madam. Yes,
nowadays, the most effective parenteral anticonvulsant is injection Levipral. And it is more effective than magnesium sulfate as far as, aborting the convulsion is considered. But you are very right in saying that the moment there is a recurrence of convulsion, because now there will be higher chances of other systems getting compromised. So it's possible better to shift the patient to ICU, or at least to make sure that every facility is available in the HDU itself, and the physician, neurologist, and can be involved. Another important thing is when the severity is so high, maybe there is a role of brain imaging, and MRI or CT scan will definitely help. CT, especially if the patient has already delivered, then it will deliver. Definitely it will be a sensitive marker of anything worse which has happened than eclampsia. So these are the things. Yes, the respiratory.
Thank you so much for the inputs, madam.
Yeah, system should be really protected now because the aspiration chances are so high. So a lot of protection is needed. So airway and then management. So probably it's best to take her to the ICU. Yeah.
Now, when do we terminate the pregnancy?
Sir, after stabilizing the patient, after getting all the investigations and giving anticonvulsant line of management using magnesium sulfate and reducing the blood pressure, the immediate goal is to terminate the pregnancy. And if the general condition of the mother, all the investigations are normal and the average size baby, pelvis adequate, and there is no cephalopelvic disproportion and Bishop score is favorable, ideal would be an vaginal delivery, where we cut short all the 3 stages of labor. Even if it is one finger loose, we do an ARM and start with an oxytocin and cut short the second stage of using an outlet forceps, and third stage using an active management of third stage of labor. And C-section should be preserved only, should be indicated only for an obstetric causes, indications.
Yes, thank you, sir. Thank you so much. That means there is no scope for continuation of pregnancy once there is a eclampsia. So most important is that eclampsia should be delivered at a tertiary center. So should not be managed in the peripheral area as quickly as possible. Patient should be referred to a center where all other facilities, delivery facilities, and also ICU management is available. How do you manage?
Can I have a doubt here?
Yes, madam.
We used to hear of this term called intercurrent eclampsia, wherein the pregnancy continued even after an episode of convulsions. and especially so when it was preterm or when we wanted to wait for the effect of the steroids to take over. How
Yes,
do we
ma'am.
base this now?
But according to the guidelines, intracurrent one patient should not develop one more convulsions, madam, because that is more grave risk and mortality is very high when than allowing the patient to continue in spite of the convulsions. Earliest studies were showing that it can be continued, but maybe in the centers where patient is managed much more carefully. But here for guidelines are suggesting that definitely we should not continue the pregnancy once there is a conversion is present.
Right.
Yes, thank you, madam. How do you manage after the delivery? Sindhu, madam?
So, delivery also continued surveillance is very important of the lady. It's very important we continue the max self at least for 24 hours after the delivery. It's important that antihypertensives are also continued. And usually the risk factor is around 3 to 7 days. That period has to be stressed and her vital monitoring has to be done. It's important that we avoid NSAIDs. And you should encourage her for breastfeeding. And in view of the risk factors, you can also start heparin, promote the early ambulation and also hydration, good amount of hydration. It is in case of early onset preeclampsia, it's very important that we evaluate her for autoimmune diseases. APLA test should be done at least 6 to 12 weeks post-delivery.
Yes, thank you, madam. Thank you. Thank you so much. That means magnesium sulfate at least should be continued for 24 hours after the delivery or 24 hours after the last conversions. So these are the, just now madam had mentioned, to prevent the thromboembolism in a postpartum period, early ambulation, hydration, and breastfeeding should be continued. How long should we continue the antihypertension in the post-delivery? Harish, sir?
Sir, it has to be continued this one until 3 months after the delivery, and continuous monitoring of the blood pressure has to be there. So, and during this period, encouraged to use the contraceptives also up to the 2 to 3 years, according to either IUCD or progesterone only pills can be used this one.
So what we should understand that preeclampsia hypertension can come back to normal. It may take up to 3 months sometimes. That means 12 weeks should be wait for preeclampsia itself. So later than if it persists beyond 3 months, then you should consider as a case of chronic hypertension. So we can wait for up to 3 months for the preeclampsia blood pressure to come back to normal. So and in this mean period, to prevent the one more pregnancy, definitely patient should be advised to use the contraception. IUCD is preferred, or the patient doesn't want. If the patient wants within 6 months, then progesterone only pills can be used. And later 6 months, then combined oral contraceptives also can be used. So this is the end of management of the eclampsia and also preeclampsia. I just want each panelist to put one concluding point. Lata madam.
So prevention is the best option for eclampsia. And for we should try to
1
prevent
minute, Lata.
Yes.
ಒಂದೇ ನಿಮಿಷ. Screen share stop ಮಾಡ್ಕೊಂಬಿಡಿ if you don't have any more information. Yeah, it gives a better connect to have a gallery view. Thank you. Stop.
Our goal should be for prevention of eclampsia completely, and as much as possible to prevent PIH, early onset PIH, to the maximum extent, with proper screening and prediction of preeclampsia.
Stop share ಮಾಡ್ಬಿಡಿ ಇವ್ರೆ.
ನಾನು ಸ್ಟಾಪ್ ಮಾಡಿದ್ದೇನೆ ಮೇಡಮ್.
I'm still seeing the shared screen.
It may take some time to see you, madam. I have stopped.
Yeah, thank you very much. Yeah.
Yes.
Yeah, continue. Please continue.
Manohar, sir.
Excellent panel.
Yes, sir. So we know because nowadays one of the most important cause for the maternal mortality, we are seeing 20-21% of the because of HDPs, hypertensive disorders. So as madam said, one is prevention and most important is counseling during the regular antenatal checkup and motivating and the low, like in the PHC levels, the importance and explaining the risk and complications and early referral. All those has to be counseled to the maybe in the PHC level for staff nurses or for the PHC level doctors. So early referral, because most of them, the patients, they do come with a late stage having an eclampsia, and sometimes we have seen in the government institute the patient being brought dead. So it's early referral, early identification, prevention, early identification, and early referral would probably lead to decrease in the morbidity and the mortality in these sort of.
Thank you, sir.
Yes, sir.
Sindhu, madam.
So we have all known that preeclampsia is not just hypertension, it's a progressive multi-system disorder. So it's very important that we teach her the lifestyle changes, the various physical activity, avoidance of all the risk factors, smoking, alcohol. Very important on follow-up with her regular postnatal care. Then very important for coming up with the preconceptional counseling also to assess the risk factors so that the recurrence rate can be reduced.
Yes, thank you. Harish, sir.
So we discussed so much about the Gestosis score actually. So this Gestosis score, every time the doctor only cannot be may not be able to perform because of high caseload in the government colleges and all, like government hospitals and all. So this has to be given training regarding this. Training has to be given to the even ASHA workers also and peripheral health workers also. So they are the one who are getting connected to the patients very frequently at their home, at their convenience. So they can open up with all the so many factors are there, history related, like so that can be elicited at their home, at their convenience by these ASHA workers. So we need to get trained those ASHA workers or peripheral health workers regarding this Gestosis score actually, one thing. And clinical related, of course, the patient when throws a fits. So the first thing that has to be done is not to become panic and call for help. So that is the main thing that we need to train our junior doctors, because majority of the time it is the junior doctors or the house surgeons, they are there with the patient continuously actually. So not to get panic and call for the help. That is the one message we need to give to the junior doctors.
One thing I want to tell, while doing the counsel, we have to counsel the patient attenders than the patient in our country, especially. Along with that, we have to reduce the workload on her. If she is outside working, we have to ask her to stop working. In house also, we have to tell their attenders to take her bed rest. That is the main thing. If you tell the patient, it is nothing useful. You have to counsel the patient attenders.
Yes, thank you, madam. Aparna, madam. Dr. Aparna. Dr. Ramya.
Sir,
Yeah.
as Harish sir said, we should concentrate more on the Gestosis score. Now in our Thai card, we have Gestosis score printed in our Thai card, unless other states. So we should always encourage for the Gestosis because it's one of the easiest way of screening and start aspirin. One more thing is the postnatal adherence to the antihypertensives. Most of the times we'll be very sure about our antenatal management and the intrapartum management. But when it comes to the postnatal side, probably the patient might stop or we might sometimes stop monitoring. So we should educate the patient and her party about the postnatal follow-up and the postnatal adherence to the antihypertensives.
Thank you. Thank you. If there are any questions, they can unmute and ask the questions. If any participants, if they are.
Dr. Ravikant, there are some questions in the chat box.
Yes, madam. Checking, madam. Yes, madam. Use of BP apparatus like mercury, aneroid, automatic, multi-para monitor encouraged, or one question is which BP monitor should apparatus should be used to record blood pressure? Anybody wants to take this question? Lata, madam.
So we can use mercury also, and for home monitoring, we can ask them to use digital monitoring. But in the hospitals, usually we use mercury.
Yes.
Mercury, because of nowadays.
Mercury is not available.
It is the Ravikant, it is the technique rather than the device.
Yeah, that is correct, madam.
I think that is more.
The bladder of the cuff should be middle side of the arm, and the BP cuff should be covered in the 2/3 of the arm, and patient should be sitting, and our arm should be rested on the table, and patient should not have crossed their legs while recording the blood pressure. If you maintain this posture, and blood pressure recording will be accurate. No need to continue the long once BP is normal. Continue. Okay, it's somebody has answered it. Antihypertensive come. What are the options? What are the options if labetalol are contraindicated as in bronchial asthma?
Let's start with.
Yes, sir. Manohar, sir, please.
Yes, sir.
They are asking if the labetalol is contraindicated, what they should.
We can start with the nicardia triads. Nifedipine can be used as an alternative.
Nifedipine can be used. There are other antihypertensives are also there. Itralin is there.
Amlodipine.
Hydrolazine is available
Yes.
now.
Yes, sir. Are there, but most of the time, most of the patients till now we have seen, they are controlled by either labetalol or nifedipine. They are very well controlled. So
usually when pulse rate is more than 100, we prefer labetalol, and pulse rate is less than 100, we prefer nifedipine, because the nifedipine causes little bit tachycardia. So when pulse rate is more than 100, labetalol can be started, and when it is less than 100, nifedipine can be started. So other drugs, like as you said, hydralazine, all those things can be used, like sodium nitroprusside for severe preeclampsia.
Correct.
That also can be used.
Ravikant and Geeta,
Yes, ma'am.
there has been often this concept of, the heart being responsible for hypertension. For example, sometimes people speak, physicians, not obstetricians, they speak about systolic hypertension, and people speak about higher peripheral resistance than diastolic, like diastolic hypertension, like that. And as Lata also said, the heart rate also matters. So it is sometimes felt that when the systolic BPs appear to be higher, then probably what will help is something like levodopa, which will, balance that. And if there is a very strong peripheral vasoconstriction, as reflected by a very high, the diastolic blood pressure, then maybe nifedipine will help. So when we choose, I think we have to.
Yes, madam.
Muralidhar sir, some questions are for you also is there, sir. Muralidhar sir.
Service now.
Muralidhar sir. Arun. Arun sir, idhara nodi.
Sir is not there, madam.
Not there, ma'am.
If there are any other questions, sir, they can unmute and ask almost all the questions.
They have asked what antihypertensive is preferred post-delivery or postpartum hypertension. I think post-delivery, it depends on the patient condition also. If she has got generalized edema and all, we can add diuretics also for a brief period for 5 to 7 days, along with the antihypertensive like labetalol and nifedipine can be continued post-operatively also, or post-delivery also. Along with that, we can also add diuretics for a brief period.
Yes, madam. And we thank Geeta madam and Rajshri Paladi madam, Shobha madam for giving us this opportunity. I thank all the panelists for active participation, and thank the expert also, Dr. Ramya and Dr. Aparna madam, for being contributing to this panel discussion. Thank you. Thank you.
I should actually congratulate Dr. Geeta for selecting excellent topics and speakers. And I think in a webinar, we crossed 200 members. And it was a very, very good response and very interactive. Any amount of discussion on this particular topic is always welcome. And I think, Ravikant sir, you have done a wonderful job. And Muralidhar Pai sir, as always, has cleared the concepts very nicely. And Dr. Geeta, thanks for taking up such good efforts, and hope that in future also we keep up the good work going.
I agree completely with Rajeshri. And Manohar very well pointed out that in recent times, the mortality due to HDP has actually increased in the public sector. I have I have been part of maternal death review at the state level, and when we look at the problems, I think Ravikant has brought out very relevant points today for eclampsia management. And whatever you said is you should encourage primary healthcare obstetricians and physicians to give the loading dose of magnesium sulfate before they shift a convulsing woman for higher care. That will save lives and not to delay. So the first dose of magnesium sulfate, actually, they should not hesitate, the loading dose. So that kind of training should become possible from Kasova. It is very heartbreaking to see young girls dying because the loading dose was not given. And well, by the time they are shifted, they would have aspirated, and then they are beyond repair. So deaths are still happening due to eclampsia and hypertension and complications. So very well done by Safe Motherhood Committee for bringing this to light. Very good discussions, and keep up the good work. And
Only one request, we have to ask the government of Karnataka to add a one chapter related on pregnancy, madam. There is no health chapters will be there in the school or colleges, which is very important. That we can done through Kasoga, madam.
education level,
Education
so
level.
ದೊಡ್ಡ ಕೆಲಸ ಅದು.
ಅದೇ
I
ಮೇಡಮ್,
think it is the
ಪ್ರೆಗ್ನೆನ್ಸಿ
biggest
ಬಗ್ಗೆ
job to
ಪ್ರೆಗ್ನೆನ್ಸಿ ಬಗ್ಗೆ
influence
ಎಲ್ಲೂನು
textbook for
ಹೆಲ್ತ್
school. ಗೀತಾನ್ ಇನ್ನೊಂದ್ಸಲ ಬರ್ದು ಬಿಡ್ಬೋದು, ಅದ್ ಮಾಡಕ್ಕಾಗಲ್ಲ. It's very huge, Geeta.
ಅಲ್ಲ
Because
ಮೇಡಮ್,
I'm
ಒಂದು
telling you,
ಏನಾದ್ರೂ ಪ್ರೆಗ್ನೆನ್ಸಿ ಬಗ್ಗೆ
too
ದೇರ್
much.
ಇಸ್ ನೋ ಸ್ಕೂಲ್ ಟೆಕ್ಸ್ಟ್ ಅಲ್ಲೂ ಇಲ್ಲ, ಯಾವ್ದ್ರಲ್ಲೂ
Yeah.
ಇಲ್ಲ ಮೇಡಮ್, ವಿಚ್ ಇಸ್ ವೆರಿ ಇಂಪಾರ್ಟೆಂಟ್ ನೌ ಡೇಸ್.
Correct. That will work towards
ಪೇಷಂಟ್
primary
ಎಜುಕೇಶನ್
prevention.
ಪೇಷಂಟ್
It
ಎಜುಕೇಟ್
will
ಆದ್ರೆ
work for 50 years. No, what we can do is we can increase training I really believe a lot in training. So
ಟ್ರೈನಿಂಗ್ ಪ್ಲಸ್ ಪೇಷಂಟ್
if you
ಎಜುಕೇಶನ್
can
ಇಸ್ ವೆರಿ
take,
ಇಂಪಾರ್ಟೆಂಟ್ ಮ್ಯಾಮ್.
yes, so if you can take a paramedical training, awareness, even medical officers training, consultants reinforcement of all this knowledge, encourage them also to train their own staff, that probably will have also. What you say is very right, Geeta, but we must look at short-term goals. Otherwise, we will not get anywhere. For example, Dr. Rajeshri has 1 year to perform. So she should see within this year what constructive she can do. Likewise, you have 2 years as a chairperson. So you should see what you can do because soon somebody else will take over from you, and then they deserve their own place, their own work. So therefore, focus on short-term goals and see what you can achieve. Of course, whatever you say, you should project it and put it somewhere as an article, and hopefully somebody will take it up. But what we can do in our everyday work, you please start doing that. So anyway, this was a very good experience for me also. Dr. Pai has logged out, is it?
ಸರ್ ಹ್ಯಾಡ್ ಸಮ್ ವರ್ಕ್ ಇಟ್ ಸೀಮ್ಸ್
ಹೌದಾ?
ಮೇಡಮ್, ದಟ್ಸ್
ಓಕೆ ಓಕೆ. ಅದೇ ಚೆನ್ನಾಗಿ ಬಂತು, ಬಹಳ ಚೆನ್ನಾಗಿತ್ತು. ಎಲ್ಲರೂ ಲಾಗಿನ್ ಮಾಡಿದ್ರಿ. ಎನಿಬಡಿ ಎಲ್ಸ್ ಅಪಾರ್ಟ್ ಫ್ರಮ್ ದ ಫ್ಯಾಕಲ್ಟಿ who joined, anyone can have any opinion, can please say so, and please proceed with the vote of thanks. Thanks. I'm really privileged to be part of this, Geeta. Thank you very much.
Thank you. I thank Shobha Gudi madam also. Madam has joined. Whether madam is there or not, I don't know. She has joined in between.
Thank you very much.
Suman Gaddi madam, sorry. Suman Gaddi madam.
ಸುಮನ್ಗೆ ಕೇಳಿ ಏನ ಹೇಳ್ತಾರೆ. ಸುಮನ್, ಆರ್ ಯು ದೇ?
ಮೇಡಮ್ ಮಧ್ಯಕ್ಕೆ ಜಾಯಿನ್ ಆಗಿದ್ರು, ನಾನು ನೋಡಿದೆ, ಆಮೇಲೆ ಮಧ್ಯಕ್ಕೆ.
Please proceed, Geeta. It is quite late.
Thank you, ma'am. Was a very elaborate discussion which dealt with each and every aspect of preeclampsia and eclampsia. So at the outset, I thank all the Kasoga for this conducting this very beautiful, wonderful webinar. I thank the President of Kasoga, Dr. Rajeshri Paladi ma'am, and Secretary General Dr. Shobha Gudi ma'am for their constant support and encouragement to conduct such webinars. And I also thank the patrons of Kasoga, Dr. Hiremet sir and Dr. Nagaraj sir, who always support such academic activities. I sincerely thank Dr. Suman Reddy ma'am, President-elect, and Dr. Durga Das sir, the past President of Kasoga. My sincere thanks to Dr. Shobha Bembalgi ma'am, Honorary Treasurer of Kasoga, and Dr. Soumya Mani ma'am, who is an EC member of Southwest Zone. My heartfelt thanks to Dr. Muralidhar Pai sir, who has logged in from Sikkim and has given a wonderful talk on predators of preeclampsia. And I also thank all the chairpersons, moderators, and the experts who have made this webinar a very successful one. And thank all the panelists for their active participation and answering all the queries of the members who have asked their doubts regarding that. And I sincerely thank all the participants who have participated in this webinar.
Yeah, very important to thank the audience.
Yes, ma'am.
I also really thank everyone that they joined it today. Thank you.
Who have logged in very huge numbers and shown their support for this webinar activities. And I also thank Mr. Arun for helping in coordinating this webinar. And my sincere thanks to again Kasoga for this wonderful opportunity given to the society. Thank you, madam.
Thank you, ma'am.
Thank you. We can end.
Thank you. Thank you all of you once again.